the challenges that you find in diagnostic MRI, they are translated into MR thermometry because it's a gradient echo sequence.
Of course. Yeah.
From today's episode, we know that MRI is a toxic relation.
No. I mean, so the whole idea behind that is to find a suitable MR parameter which is temperature related, and you can use it in real time. It's a limiting factor.
Yeah, I can imagine, because there's claustrophobic patients. They can move as well during the scan, because an hour and a half is a long time.
But how the MRI fits in this specific process?
Here you also use different parameters of the MRI to measure the temperature within that, let's say, cancer.
In clinical practice, we're using gradient echo sequences.
So you use spoiled gradient echo, right?
Yes, any type of gradient echo you can use.
We never heard of this until we spoke about it. I find it fascinating because it's really, really interesting.
It's more like a dynamic scan where the patient needs to give you this constant, response about like a specific stimulus.
Can you reproduce the same result with the same patient over and over again, or you have the patient once and that's it? So basically, what we're trying to do is to correlate the images with the temperature maps with an actual temperature measurement.
When I read the word MR thermometry and MRI hypothermia, I was like, okay, what should we talk about now? I was a little bit confused. I was like, okay, what is this topic actually? I'm very ignorant about. And then I saw some of your research and I was like, wow, this looks very interesting. I want to know more. Yeah. So I feel we're very lucky to have you here, Spiros.
Absolutely.
Would you like to tell us a little bit more at first about yourself and about your research as well, and also introduce the topic of the day, of course, MR thermometry and hyperthermia.
Okay, thank you for having me, guys. It's really nice pleasure talking with you. So when you first hear, let's say, hyperthermia, it sounds a little bit exotic because it's a very specialization of MRI. So my name is Spiros. My origins from Greece, and I studied physics at the University of Crete, and then I did a master in medical physics, Athens. And then I decided to pursue a PhD, and I applied for a Marie Curie fellowship. And I started my PhD in Munich. And the topic of my PhD is how to improve MR thermometry during hyperthermia treatment. Okay. So I think we will get into these words and try to give.
Yes,
I think it's interesting if we just decompose those words to try to understand. Because me and Julian, for example, we don't know much about the topic, and I'm pretty sure whoever is at home will have exactly the same questions.
Yes.
And one of the questions that I had straight away was the hypothermia term. For me sounded a bit misleading.
Okay.
Because the temperatures we're using is 40 to 45 degrees, something like that?
Yeah, you start from 37 and you go from 43 to 45.
Wow.
This is mild hyperthermia as a term, you can say.
So why they call it hyperthermia then?
I think the origin is Greek, actually. So hyperthermia, it's like you increase the temperature, this is what it means.
Okay.
If we can describe it in English.
Yeah.
Yes. So, so basically the definition of mild hyperthermia treatment is defined by the range of temperature that you want to reach in your target, and you start from 37 to 44 until 45, let's say, for 60 to 90 minutes continuously. And if we want to give a general definition of hyperthermia treatment, it's an anti-cancer treatment which is combined with other treatment modalities like radiotherapy or chemotherapy or immunotherapy. And the aim of this therapy is to elevate the tumor temperature up to 45 degrees Celsius for 60 to 90 minutes. Yes.
Okay. But basically you burning the tumor, the cells.
You are not, you are heating the tumor.
Heating it.
Because there is also the thermal ablation part.
Yep.
Which you start from 50, you can reach up to 100 degrees Celsius. Wow. so from 50 degrees to 100 degrees Celsius. So basically you destroy the cancer tissue.
Okay.
Fantastic. But
Yeah.
how the MRI fits in this specific process?
Yeah, that's a really nice question. And because during MR-guided hyperthermia now, you want the MRI is arise. So basically, MRI is the means where you can visualize the temporal evolution of temperature within the target tumor with a very good temporal resolution and spatial resolution and in 3D.
Okay.
So the quality of the hyperthermia treatment actually is dependent on the temperature, on the final or the maximum temperature within the tumor. So if you don't have the MRI, you cannot check if you reach that temperature for the time period that it is required to be effective. Yes.
I read one of the articles that you sent me, and I saw that the T1 relaxation also
Yes.
is influenced by the field, of course, that we're using. So what normally are the fields that you use to do this? They're color maps, basically, right? You have the specific
Yes.
MRI brain image, for example, and then you have a color map in it. What fields are you using? Because the field will change the relaxativity of T1, for example. So is always the same field, 1.5, 3?
Usually it's 1.5
Okay.
Tesla, but for thermal ablation again, it is done in 3 Tesla.
Okay.
Okay.
Because of the
Yes.
spatial resolution as
Because
well.
I suppose because it's the spatial resolution. This is a question that I don't have a clear answer. Why all the companies
Yeah.
that they provide the hybrid system to do MR-guided hyperthermia, why they chose initially the 1.5. I believe it's because it's the most usual strength of magnetic field that they use for
Yes, the
diagnostic MRI.
most common one, yeah.
It's a common one. But of course, there are studies that they did. They evaluate the MR thermometry performance in 0.35 Tesla. So it's not like a limiting factor. You can go up to 7 Tesla, for example. But why they chose 1.5 Tesla? Yeah, I don't have a clear opinion about
It's fine.
that.
We're all learning with each other.
Yeah.
Exactly.
Yeah,
We're
yeah.
here for that.
I think
And
it's a good thing to go back and
exactly.
we can all search.
Yes.
And about this, I want to ask you before diving a little bit deeper on how MR thermometry fits on this entire, discussion. Meaning, you already mentioned that hyperthermia, and now how do you combine it? Are like two things that are in the same overreaching discussion, or are two separate things?
So first of all, about MR thermometry, as you said before, it's basically the MRI color-coded with respect to temperature, which means the red, simply speaking, the red means a hot region, the blue means a cold region.
Yeah.
Okay.
And for MR thermometry, it's basically how, as I said, how you see the temperature within the tumor region.
Okay.
And of course, during MR-guided hyperthermia treatment, you have two systems combined together with a special filtering, because you want two things: first to heat and then to see simultaneously. So you have heating applicator, and you have the MRI working simultaneously together. And of course, these two systems cannot interfere with each other, because you will have MR artifacts. And there is a special filtering that is be done during the installation of the hybrid system. And there are many tests that you can check if these two systems interrupt the operation of one another. And you can see it pretty clear in the MR thermometry map, as we call it. Yes, so you can think about it. Now, because we mentioned the term MR artifacts, the disadvantages of MR thermometry are strictly related to the common MR artifacts that you can see during diagnostic MRI.
That was one of the questions I had for you. Yeah.
Yes.
How you overcome those artifacts.
Yes. Okay. But before we go there, I think it's we have to describe a little bit the MR thermometry techniques.
Please.
Yes, there are many. Okay.
Okay, so we are actually very.
There are many.
Okay, we discussed about the
Yes.
MR thermometer,
Yeah.
thinking it was. So there are many.
There are many.
Okay.
However, each method has advantages and disadvantages. So you have to keep a balance, and you have to find the good candidate, the good parameter, MR parameter, that you can choose and monitor the temperature. So there are, as I said, there are many, and you mentioned T1,
Yep.
T2, relaxation parameter. There is magnetization transfer, for example, and the proton resonance frequency. Okay.
So
The
we
proton
use-
density.
So we use the chemical shift then.
Yes.
Yeah. Okay.
So the whole idea behind that is to find a suitable MR parameter which is temperature related, and you can use it in real time to correlate this parameter to temperature. So you want to find a relationship between the MR parameter and temperature,
Okay.
and you need to find this parameter. And as I said, it has advantages and disadvantages. And the proton resonance frequency shift, as we say, is the one that is widely accepted all over institutes. And basically, MR thermometry in clinical practice works based on that. So proton resonance frequency shift. We can discuss a little bit the physics in an abstract manner behind
Yes, yeah.
this. But I think it's very simple because you mentioned chemical shift. And but let's say if we have water-based tissue and we have hydrogen bonding between the protons of neighboring water molecules.
Yep.
Okay.
Yeah.
And as you increase the temperature, this hydrogen bonding becomes weaker. So the electron shielding of the proton increases. And the electron shielding depends on temperature in a linear manner.
Yeah.
So the way to monitor this is by phase imaging.
Okay.
And
And this is why you need also like a high temporal resolution in this sense.
What you're mentioning is, so we have T1 is one of the ways to do it, right? But we can do it with T2, we can do it with different parameters of MRI.
yes,
This kind of reminds me, of course, it's nothing to do with it, but it's kind of analog to spectroscopy, where you also measure different types of, you have different measurements there as well. So here you also use different parameters of the MRI to measure the temperature within that, let's say, cancer.
in clinical practice, you do it only with the proton resonance frequency shift. You
Okay.
can do it with T1 or T2. And actually, during my master, I did it with T2, but quantitative MRI. So
Okay.
I didn't use the multi-echo spin echo sequence and monitor the temperature with the signal intensity. I used this type of sequence in order to quantify the T2 parameter. And from the T2, again, there is a linear relationship with the temperature. So you go from T2 maps to temperature maps.
Yeah. Okay. Just
Yeah, that now is clear, I have to say.
Yes.
But it seems to me, and again, from someone that knows very little about this, is that you mainly work on intrinsic parameter, meaning those parameters that are intrinsic in the human body, those that we cannot change. But are you also like manipulating any extrinsic parameter like TR, TE, those that are affecting the standard image, like the standard sequence, or you mainly focus about T1, TE, proton density, those kind
Before
of
we
parameters?
go there, I think it's worth mentioning why we chose to use the proton resonance frequency shift.
Yeah.
The main advantage over the T1 or T2 is that it's tissue independent. So basically, if you want to use the T2, for example, different muscles, let's say different regions of the body, have a different relationship of the T2 with temperature, different linear relationship. But with the proton resonance frequency shift, this relationship is standardized. It's linear. and you don't need to do any calibration, for example, to find the relationship between the MR parameter and the temperature. It's a standardized formula. It's very easy, and so you can use it in clinical practice. And to go back to your question, the type of sequences that you are using, because you are doing more or less phase mapping.
Yeah.
You are not using the magnitude component of the signal.
Yeah.
And in clinical practice, we're using gradient echo sequences.
Gradient echo,
So you use spoiled gradient echo, right?
Yes,
Okay.
any type of gradient
Okay.
echo you can use, and by definition you cannot use spin echo sequence because the spin echo sequence, what it does is that it uses refocusing pulses, and any inhomogeneities of the magnetic field are restored, are compensated. Yes, so we want, as I said, the phase changes with temperature, okay, and this of course creates inhomogeneities, temperature-induced inhomogeneities. But if you are using a spin echo, these inhomogeneities are gone by the TE. So you want this phase variation because with this phase variation you can go back to the temperature, simply speaking. And there are some studies that they used fast spin echo sequences, but they were modified.
Yeah.
And the one characteristics of these studies is that they introduced a delay time, as they call it, between the echo time, between the refocusing of the spins and the echo time, to have these phase variations due to temperature.
That's interesting.
However, the way to do it, to apply spin echo sequence for MR thermometry, it's quite complex. And also the sequences that you are using are quite slow compared to gradient echo sequences.
So gradient echo is the gold standard.
The gradient echo is the gold standard, and the dual echo gradient echo is the gold standard.
So gradient echo, I'll give you an example, like the balanced steady state free precession or the spoiled as well. They tend to be quite affected by field inhomogeneities.
Artifacts as well.
And artifacts. So how do you manage? Do you do like a manual shimming when you acquire the sequences? How do you cope with that?
More or less, these things are checked during the QA of so before the treatment.
Yeah.
1 day or a couple of days before. There's this dedicated fandom where you check all these things. The simming, if you have inhomogeneity, B0 inhomogeneity.
Yeah.
And the fandom is quite simple. It's a cylindrical fandom with a material within it that has the same properties as the water-based tissue. And there is a standardized protocol that they use in order to check all these parameters. So everything is validated before the treatment.
Okay.
So I have two questions for you.
Yes.
Two in one.
Okay.
So I can imagine this is a multidisciplinary team, right?
Yes.
Working there. So basically it's not just the radiographer, it's the researcher, it's the radiographer, probably the cancer doctor, the planning, all of that is involved because it's a hybrid environment, right? How do you guys manage that process with so many people working for one patient? And you were telling us that you do the QA beforehand. Can you guide us through the process of doing that treatment? Yeah. So basically the flow from since the patient arrived or before the patient arrives, because you're saying you guys do the QA before that. Can you just guide us through that process so we have a better idea of how that treatment goes?
Okay. Again, I will describe it in an abstract manner, in steps, so that we can get the basic. There is a term that they call, exists of course, hyperthermia treatment planning.
Yeah.
Okay. So before the treatment, the patient does CT or MR. We are using the CT or MR of the patient, and we are doing the hyperthermia treatment planning. Hyperthermia treatment planning is done so that you can see where is the tumor, and you can. There are softwares that you can use, and you can optimize the device, the heating device characteristics, so that you will have maximum temperature heating in the cancer's tissue, and you leave out the healthy tissue.
Yeah.
So
So there's no risk to actually affect the surrounding tissue while you're doing any of this.
in general, everything is a risk. Okay, but
True.
yes, so no one can validate that everything will be perfect because nothing is perfect.
Absolutely.
Yes,
But is there like a
big-
significant risk, or is like something?
I wouldn't say. So I'm not so much in the clinical workflow because you can say that I'm kind of fresh in this field 3 years. But throughout these 3 years, I had the opportunity to see how this workflow is done.
Yeah.
And from my experience, and because I have seen many patient treatments, there was not a big, how to say, risk
Yeah.
for the
So
patient.
there were no specific consequences of this treatment.
No, and this is the tempting part of hyperthermia, that you can use it to boost the radiotherapy
Yeah.
or chemotherapy without any serious side effects for
So
the
we can
patient.
summarize it by saying that the benefits outweigh the drawbacks.
Yes.
So, yeah. Okay.
So you can increase the dose of the radiotherapy by using hyperthermia and lowering the radiotherapy dose. So you can avoid toxicity, patient toxicity related
That's
adverse
great.
effects.
Yeah.
So
Absolutely.
that's why they are using it in practice right now.
Perfect. Sorry, I interrupt you when you were doing the
Yes.
flow. Sorry.
Okay. So can you repeat your question? Because
We just want to understand the flow,
the
all the way
flow.
to MRI thermometry. So how we get to one point to the other.
Yeah. So during the treatment planning, you can optimize the device settings, the heating device settings, to achieve maximum temperature in the region, and then again, maybe we will go back to this again. It's a nice opportunity to introduce that term right now. As I said, hyperthermia is done with radiotherapy, chemotherapy. Okay, the timing in between these two treatments is very crucial. So the ideal scenario here would be to be simultaneously. So hyperthermia with radiotherapy, or at least to minimize the period in between these two treatments. And in Munich, they are doing chemotherapy simultaneously with hyperthermia to maximize the effect of hyperthermia, of chemotherapy. So the patient comes by, and there is a setup, so which takes 1 hour, for example, to position the patient within the heating applicator.
Because there's a lot of hardware, basically. That you need to
I
use.
would say yes, there is the heating device, which encloses the patient treatment region.
Okay.
And this goes within the bore of the MRI. So the basic components, I would say there are two: the heating device and the MRI.
Okay.
However, there is a third component which we didn't talk about too much, but we can say that after answer your question. And so this takes 1 hour. So the patient preparation and all of that takes 1 hour, and after that you begin the treatment, and usually takes 1.5 hours, which is a lengthy procedure, and that's not a good, let's say, it's a limiting factor.
Yeah, I can imagine, because there's claustrophobic patients.
Yes.
They can move as well during the scan, because an hour and a half is a long time.
Yeah, that actually, this is I would say like a perfect statement. Do they need to, I would assume they need to remain still for the entire amount of time, right?
Yeah, the ideal scenario is, again, the patient to be still in order not to have intrascan or interscan motion artifacts in the MR thermometry maps.
How long is going to take the gradient echo sequence itself?
1.5 minutes.
1.5 minutes.
Yes.
Okay. So it's like one sequence after the other.
Basically, you apply. In other institutes, they can do it otherwise. But the treatment protocol that I have seen, it's every 10 minutes you apply the gradient echo sequence, and simultaneously you are heating. Perfect. And you visualize the temperature in the whole FOV
Okay, interesting.
Yes. So every 10 minutes up to 90 minutes.
And
at
during
the end.
those 10 minutes, there's a break, or you're doing any other kind of scanning? Or
You can do, for example, you can try another sequence for another reason, or you can always check the patient. So the patient feedback is crucial.
yeah, absolutely. That's one of the questions I had for you, the communication as well, because at the end of the day, we're hitting them up. Do they feel that, or is something that they probably report to you?
From what I asked,
yeah,
because I have tried it myself as well.
You've tried it on you?
Yeah.
Okay.
Yes.
no, that's good. That's good.
Yeah,
that,
it's
that you
good
tried
to-
on yourself, so you know exactly how
Dedication.
Did you get one of your tissues?
I did a checkup.
Okay, that's
And then yes, so it depends on the level of the heating, the depth of the heating.
Okay.
From the patient's skin. So if it is like the tumor is deep-seated, soft tissue sarcomas in the pelvic region or in lower extremities, they feel it as a pressure. And if it is more superficial heating,
when you have most of the pain receptors, so
it's
probably that's when you feel
it
more
is more like heating, I would say.
Wow. So there is
but-
this constant feedback of the patient.
Yes, but these are not usual scenarios.
Okay.
So most of the patients do not
feel anything.
have major complaints regarding
Yeah.
the treatment. But there is as all MRI examinations, there is a continuous patient feedback, and
That's interesting.
if they say that I'm feeling pain or I'm feeling that I'm heated too much in this region, you can reduce the power of the heating device, and then you can let the time pass a little bit, and then you re-ask the patient if it is better, and if he or she says yes, now it's fine, you understand that this pain is power dependent. Other sources of a slight pain is of course that you are sitting in the MRI for 1.5 hours, so you have within the applicator a water bolus, as we say it. This water bolus is mainly for two reasons: for electromagnetic coupling and also for water cooling.
To lower the temperature.
Yes, so I think it's quite normal for the patient to feel a little bit pressured in the treatment region.
Do you do these treatments across all ages, or it's more adults? Do you do pediatrics as well, or it's a adult kind of
It's not
tool?
no, it's not adult. It's not restricted by age. So
Okay.
I have seen many even under 18 to have soft tissue sarcomas, and they're doing hyperthermia.
Wow, interesting.
Yeah.
Yes.
Sorry, go
No,
ahead.
go ahead.
Yeah. No, I was just saying because we never heard of this until we spoke about it. I find it fascinating because it's really, really interesting.
Yeah.
And because I never seen it, I would love to see it one day. But do you know any clinical institutions aside from yours that are running this kind of technology? Like,
as far as I know, in Munich, it's the big center with many patients. Netherlands, Rotterdam, Amsterdam.
okay,
I have been there.
the university hospital, right?
Yes.
Yeah.
Yes. The Erasmus University Hospital.
Yes.
They have many studies with cervical cancer. So hyperthermia can be applied to many types of cancers. So head and neck, soft tissue sarcomas, as I said, bladder, cervical. Yes.
Some of the pictures that I saw in the article you sent me, the camera looks like the normal helmet of MR, but it has kind of a grid inside, like black grid. I remember that sends. I think is the MRI ultrasound.
MR-guided high focus
ultrasound. Yeah. So is it part of what we're talking about, right?
Now we're talking about mild hyperthermia. The one that you describe, it's using, as we can say, HIFO.
Okay.
For thermal ablation,
Yeah.
which is used in kidneys, and so in other clinical scenarios you can use this treatment to ablate the tissue. And there you are using, but now we are deviating for the question. But let me answer that
Sorry.
first. Yes. So Netherlands, Germany, Switzerland,
So there's
as I
quite
know,
many, quite
Yeah.
many countries. huh?
Italy, for
There you
example.
go.
Ah, there you go.
Your fellows
Yeah.
should know about it.
Yes.
No, you know what I was thinking
But
when he
not
was
not MR-guided hyperthermia in Italy. It's just hyperthermia. Yes.
when he was describing the process of collecting the feedback from the patient. It remind me a little bit to the stress perfusion. You know, that you stress the
Exactly, yeah.
patient and then you want to know if there is a response as
Yeah, yeah.
well. So this is the kind of like introduce the more like it's more like a dynamic scan where the patient needs to give you this constant, response about like a specific stimulus. So it's quite interesting. And do you think we're going to see more than this? According to your experience, do you think this is a field that is going to expand more in the future?
Interesting question. And I think my answer can be combined with some introductory points. Okay. Over the last century, I mean, hyperthermia, it's one of the oldest anti-cancer treatments, around 5000 BC. And over the last century, there were studies that they showcased the clinical effectiveness of this treatment, but there was not the technology in order to apply it. So there was not the heating device technology or the way to monitor this process with MRI. But now I think everything is developing and you can transfer from many medical areas, practices or technologies and to your area. I think now we are stepping into a gas, I would say.
And now I don't know if AI will play any role in this.
AI can play a major role. Also, deep learning techniques for reconstructing MRI, for example, from Siemens. These techniques takes raw data and make it to images using deep learning reconstruction methods. So you can use sequences, you can decrease the time of the sequence and denoise simultaneously the image. Or increase the SNR of the image without increasing the number of signal averages, okay, which takes enough time. For example, for that point, I used the haste sequence. I tried it. And another thing that we can mention is that during MR-guided hyperthermia, you receive the signal using the body coil, not the the surface coil.
The actual coil in the bore.
So the receptor of the signal is the body coil.
Okay.
Which is not a good thing, I would say, because if you are using a fast sequence like the haste, you lose signal.
It's going to be grainy.
But you also mentioned about 3D sequence. And do you use that as well? Because on that, probably the application of deep learning might be a little bit more limited at the moment. So which sequence, you mentioned gradient echo, but specifically is that you mentioned the haste is what you're mainly using?
No, the haste is something that I experimented.
You tried, okay. And is one of your experiments, let's say.
It was...
but is that like a sequence, or we can call it whichever vendor you prefer, but it's like, you mentioned 3D as well. Is that like a gold standard sequence that you use? Let's take in like...
Yes, there is, for example, in Munich, they are using the dual echo gradient echo with specific TR, specific TE, and everything. Of course, you can use a 3D, like the one that comes to my mind right now. I remember the name, but I don't know from which vendor it is. The multivane or propeller. I don't know how you...
Yeah, propeller.
Propeller.
Yeah. Propeller, blade.
Yeah. Oh, blades, for example. So you can use it as well. But first, in order to introduce it in clinical practice and you change the protocol, you must prove that this works. So either you do a phantom study or a patient study, but you need to take simple steps in order to introduce it.
I don't know if you agree, Sam, but it's still like a developing area, meaning the everyday, like an experiment like the one you, Spiros, are doing is like contributing to increasing the knowledge. It's like there is no final assumption, there is no final truth about this.
There is room for improvement. There is room for improvement. There is. And basically, another limiting factor is the inhomogeneity of the magnetic field.
Yeah.
And because I will not get into details, but as you know, that if you have an homogeneity of the static magnetic field and you are using for 1.5 hours, of course you will have the B0 will change over time.
Yep.
And this will be interpreted as a temperature because again, this has this reflects to phase. The phase of the protons are changed due to B0. So there are many ways that you can compensate for this. Basically, you monitor the B0 field at each time point of the treatment, and you use specific regions of the FOV, which are at the 4 edges of the FOV. There is a specific material which is thermally insulated, it's not heated, and you can monitor the B0 induced phase change.
Wow.
From that, you fit a polynomial. Now we're getting into details.
No, but I
you
like how the
compensate.
physics play an active
Yeah.
part on
The
this.
physics,
role on
Because
this.
usually, we sometimes we don't think about this kind of things. That for us is more like how we generate the signal. It's like going back to the basics, and we don't do it routinely. But there, it's something you need to consider.
Yes.
So,
How reproducibly is this? Can you reproduce the same result with the same patient over and over again, or you have the patient once and that's it? Do you do that?
The treatment protocol,
The treatment,
you mean?
yeah. Do you do it more than once with the
Yes.
same patient, and how reproducible it is because of these changes of the magnetic field homogeneity and everything else? So.
Yeah, so for the first part of the question, usually it happens every 1 or 2 days per week. The number of the treatments is basically from...
It's a clinical decision.
It's a clinical decision. But you do it 1 or 2 times per week to avoid thermotolerance, which is another term.
Okay. It's like drug tolerance
Yeah,
anyways.
yeah.
Like if you
It's
take
like-
too many antibiotics,
Yes.
you get tolerant to it. Okay.
Exactly. So you do not reach the same maximum temperature in the second session as in the first session. So you have to time to pass by, a similar situation. And how reproducible it is. Okay, there are many studies that they evaluated the reproducibility or precision, the performance, and I did myself for clinical treatments. The threshold to be acceptable is 0.5 degrees Celsius for precision. For accuracy, which is the agreement of the real temperature and the MR thermometry temperature, is 1 degree Celsius. Of course, in reality, in phantoms, you can achieve that. But in reality, it's not the same because you have the B0 inhomogeneity, you have the motion of the patient, you have the air in the pelvic region, susceptibility differences, which it's very hardcore
and
enemy.
it's patient dependent on the day, right?
Yes.
Yeah, all the patients are different.
Yes, the anatomy structure is complex, so it's very difficult to achieve good performance in the pelvic region, for example. In the lower extremities, you can do that, you can achieve that, because you don't have air motion.
So which is the best area that you say, definitely here we spot the best results?
I would say, based on what I analyzed and other similar studies, I would say lower extremities.
Lower extremities. So for sarcoma or those type of...
Yes, or not, let's say, lower extremity region and to the calf, for example. So you see that you can cover this whole area, anatomy area of the patient with a good reproducibility and with good accuracy. And now that we talked about accuracy, because you have to have a real temperature measurement in order to estimate these parameters. So in clinical practice, while you are doing MRI-guided hyperthermia, you are using MR thermometry for 3D visualization, but you have to have a reference. And this is done with minimally invasive temperature probes, as we call it, which are RF transparent, and they are introduced through natural cavities of the patient.
Okay.
So let's say the vagina, the rectum, the bladder, and
so you even use like catheterization, right?
Yes, but I don't want to say too many things about that because I'm not so good at how
That's fine. Yeah.
this procedure is being done. It's very it's
So
being done by
basically,
nurses.
what we're trying to do is to correlate the images with the temperature maps with an actual temperature measurement.
And this temperature measurement must be as close as possible to the tumor region because this is the region of interest,
Of course.
after all. And yes, and however, the whole goal of MR thermometry is to replace the minimally invasive or invasive thermometry. It's a very not a pleasant experience for the patient to
That's very
introduce these
interesting.
probes.
So the role of MR here is actually to assist this, renowned procedure and get gradually away from what used to be an invasive procedure.
Yes.
It's like, okay, that's...
I would say this would be a big step for MR thermometry to prove that it's better than using temperature probes because it creates other problems and it leads to for the patient not to accept the hyperthermia treatment, and I find that normal, to be honest. But as you said, there are many problems with, especially in the pelvic region, and we can go to the end and analyze a little bit more about that. But yes, as I said, the challenges that you find in diagnostic MRI, they are translated into MR thermometry because it's a gradient echo sequence.
Of course, yeah. And at the end of the day, it's a new kind of way of doing things. So there's always new challenges that you're going to face, and you have to overcome them while you're learning, right?
Yes.
So that happens with any new technology that we use.
Yes.
One of the things that I would love to understand is, imagine I want to start doing it. All right? How can I get into the field? How can I find a place where I can...
Oh, no.
Through me. You're the only point of contact.
It's a good contact.
Let's go to Munich.
No, for example, for the people at home that are listening, and for us as well, if we have the interest to pursue something like this, how can we get to it? Because as you were saying, there's a few countries in Europe doing it. I'm sure there's someone in US doing it. I'm not sure about UK. But how can we get to it? Is there a educational
platform
pathway or
education pathway?
Because it seems to be a very niche kind of thing.
Yeah.
Like, for example, if you Google it, you will find it for sure from... so there are definitions by NHS, for example.
Okay.
What about guidelines? Are there guidelines?
There are guidelines. So this is standardized, I would say.
So it's quite established already, actually.
It's... I suppose this has to come from the doctor, the decision, because it's not it's not like radiotherapy, which everybody knows.
Yeah.
So either you search it yourself and you found it and you suggest it, or the doctor must know about this treatment, and I'm sure now they are pretty much aware of the...
So from the point of view of a radiographer like us, is more of a self-taught kind of discipline. So if I want to get into it, I need to look for it, speak to people like you that is already doing it, read some articles, and try to convince my doctors to do it at my facility, or if they already know.
My perception is that you need to have the doctor that is highly specialized, which, according to what you're saying, are very few. And then that doctor that established the service, it must be kind enough, to instruct all the others, and which will be potentially the radiographer as well, on what are the tasks. But it's like, I think what also someone was asking is that, so there is no specific, I would assume, education. Let's say even a course. Is there a course that will teach you a little bit more about
an official course? I wouldn't say so, but
Spiros, we have to work on that.
Yeah, I have to, that's another gap, another room I have to fill. So but you need to have like a technical staff, nurse, an MR technologist, I would say. Yeah. Someone needs to be trained to do the hyperthermia treatment planning, for example.
So we go back to what we were talking of, the multidisciplinary team.
Yes, so you have to have these people in this specialization. There are studies that says that they are saying that there must be defined a workflow, a training, and all of that for hyperthermia. But I'm pretty sure that now, especially in Munich, they are in exceptional level to do it.
Yeah.
and are the Netherlands as well. So it's not it's standardized on its own way, for example. So the quality is pretty much high, and especially if you're a radiographer, then you know for sure how to operate the MRI. And I suspect that you have to watch treatments, ask questions.
Absolutely, yeah.
Yeah.
Just be on the field and
just
learn
be on the field and
as
learn.
you go.
This is so
on the
unique
train.
that you need to be on the field,
Yes.
see it, practice it. This is
Like
the-
everything, I would say.
Yeah.
Wonderful.
Yes.
Do you have any?
No, I
question?
don't have any additional question. Now,
Okay.
finally, I have a clue about what it is.
Exactly.
Yeah.
And today, radiographer that was working with me right a couple of hours ago, and when I mentioned I'm gonna go and talk about MRI hyperthermia and MRI, I was like, "What? What are you talking about?" Now we have an answer finally.
Yes.
So
Yes.
thank you for that. Thank you, Spiros.
Thank you for
Before we finish, there's two things. Is there anything else you think you would like to mention? Because this is a very broad
This is a very broad
topic, and there's a lot of physics involved in it. There's a lot of topics that we could touch upon, but we have a limited time. So if you have anything else they would like to say, it's the moment, and then I'll have one last question for you.
I think we covered some big points of the hyperthermia and how it is implemented. You can implement hyperthermia even with non-hybrid systems, so
Okay.
without MRI. So the MRI is another tool which makes the treatment more effective, but you can do it even without MRI.
Yeah.
Okay.
And yes, so it's not like you have to have an MRI to do that. However, I guess that MRI is expensive, and it's a limiting factor by its own. But I would say that really elevates the level of the hyperthermia treatment, and you need to be included within it.
And here comes our next
Yeah.
question.
So because the question that we ask basically every single guest is why MRI for you? So why you chose MRI in the first place? So exactly what you're just saying. So I
Yes.
think if you can elucidate us a little bit why
Why
you chose MRI
in general?
in general for you, yeah.
Okay, so-
because you were telling me you decided to do the postgrad and then you chose the MRI
Exactly.
field to
Yes.
study. So what
And I've
brought you
seen
to?
also you're very into physics, MR physics, which is
Yes.
something based on the way you were discussing. It seems something you like a lot. So
Yes, of course. So initially, I did during my bachelor, I did a thesis for MRI, but I learned there the basics. So how to do quality control
Yeah.
And measure these parameters. So for me, it was kind of introduction to the whole field of MRI. What was interesting for me, it was difficult, and
So you like a
everybody-
challenge?
It was very challenging. I like the theory behind that. I really had a good mentor that inspired me in the first place. And during my master, again, I was working on T2 quantitative MRI for hyperthermia. So for me, in general, I think MRI is a very unique tool that you can apply it in many things. And simultaneously, it's very difficult, but you can do incredible things, I would say. And yeah, pretty much that's it.
Perfect.
Yes.
yeah,
That was great.
The love and the hate of of MRI described in the perfect sense.
It's like this kind of relationship.
Everything in
which are-
MRI is a balance, anyways.
Yes,
That's
and,
great.
yeah, and these are the most addictive relationship if you think about it.
Absolutely.
The toxic ones.
The toxic
ones. Yes.
From today's episode, we know that MRI is a toxic relationship.
No, I'm kidding, but you know, it's yeah.
Of course.
Wonderful.
not that
Thank you.
easy.
I have
Thank
one
you so
last
much.
thing to ask you. If you can leave us a note, because
course.
every guest that comes to our podcast normally leaves us a nice note. So if you don't mind to do it, we really appreciate you being here.
Of course.
And just everyone knows you flew from Munich
Yes.
to be here with us today. So
Yes.
Incredible.
we really appreciate
Now
you
we
doing
need to go
that.
to Munich, definitely.
Yeah. No, we really
Whenever.
appreciate you doing that because to educate people as we do for free, it takes a lot of our own effort and time. And I wanted to thank you for that. Yeah.
Thank you very much. It
Thank you
was
so much.
a
Absolutely.
great
Thank you.
opportunity. But before we close, one last thing that I missed to say is that about the hyperboost, which apparently other students wants to know and who they want to do a PhD. The Hyperpost, it was a chance for me to do the MR thermometry in Germany, and it was in a European initiative, and it was the first one for hyperthermia. I think it was a big step for popularity, for contributing to the science behind of hyperthermia. So do check it out.
We will leave the link in the description.
The link in the description. It's quite
people can
interesting.
Absolutely.
Yeah.
We'll share that with
We'll
everyone.
And last, thank you very much for the invitation. It was a really interesting conversation.
It's a pleasure.
Our pleasure.
And we can keep in touch, whatever
Absolutely.
you want for that.
Yeah.
Thank
We'll put
you.
your contacts for everyone to follow you.
Thank you,
Thank you.
Spiros. Thank you so
Thank you.
much.
Yes.
Appreciate it. Thank you.
Yeah.